Good afternoon, everyone, and thank you for joining our webinar, Tools and Strategies for a Team Approach to Serious Illness Care and MOLST Education. My name is Kate Crum from the New England QIN-QIO, and I'll be your moderator. Before we get started, I'd like to do a few housekeeping items. This call will be recorded for training purposes. The phone lines will be muted for the duration of the presentation. However, we'd like to remind speakers to unmute their lines by pressing #6. We will take questions at the end of the presentation. I will provide you instructions on how you can ask questions over the phone, or you may pose a question in the chat box. Please make sure to send questions to all attendees. At the conclusion of the webinar, I'll provide you with details on how you can access today's recording. Now I'll turn the call over to Dawn.
Kate, it's Morgan. I haven't had a chance to mute the lines yet, so let me go ahead and do that first.
Thank you.
The leader has muted your line. To unmute your line, press #6.
Morgan, would you like me to repeat the introduction?
No, you should be good to go. I think Dawn can take it away.
Okay. Good afternoon, everyone. Welcome to our webinar today on tools and strategies for a team approach to serious illness care and MOLST discussions. My name is Dawn Hobel, Program Administrator at Health Centric Advisors, the New England QIN-QIO. We're excited to bring to you our panel of speakers to share their knowledge and experience on serious illness care and MOLST discussions. So let's review the learning objectives for this webinar. At the end of this webinar, you'll be able to explain how MOLST, the medical orders for life-sustaining treatment, fits into end-of-life care, identify the required elements of the MOLST form, describe strategies to facilitate end-of-life discussions with patient and caregivers, and determine how to implement those tools and strategies to improve the processes around MOLST. As Kate mentioned, she will be moderating our chat feature today. So let's give this a try. Please chat in and let us know who you are and what organization you are with. Great. So now let's meet today's speakers. Our first speaker is going to be Ellen Nipaola, the President, CEO, and co-founder of Honoring Choices, Massachusetts. Since 2013, Ellen has led this consumer-focused, community-based nonprofit organization to provide free healthcare planning information and tools, and to collaborate with community groups and caregivers, providing person-centered care at every phase of health. She is an attorney certified in elder and family mediation and the chair of the Healthcare Planning and MOLST Subcommittee, Palliative Care and Quality of Life. Following Ellen will be Dr. Diane Dietzen, Medical Director of Bay State Inpatient Palliative Care Program. She is board certified in internal medicine and hospice and palliative medicine. She moved to Springfield, Massachusetts to direct the palliative care program in November of 2011. She has since developed a new inpatient consult service and begun a number of projects intended to integrate palliative care into the larger health system. She has given regional and statewide conferences on palliative care and advanced care planning. Prior to joining Bay State in 2011, she planned and developed a palliative care program at the Abington Memorial Hospital in suburban Philadelphia. She also assisted with the implementation of POLST, the physician's order for life-sustaining treatment at Abington Memorial Hospital, and oversaw the education and training for nurses, staff, and residents in palliative care. She additionally served as Associate Director of the Residency Program educating internal medicine residents. Dr. Dietzen earned her medical degree and completed her internship and residency at the Temple University School of Medicine. In closing out the webinar today will be Mike Farrick. Mike is a registered nurse and licensed nursing home administrator. For the past 8 years, his focus has been on long-term care and post-acute care. Currently, he serves as the administrator for Uville Senior Care. Uville Senior Care is a 208-bed skilled nursing facility located in Lowell, Massachusetts, that services both long-term care and short-term rehab residents. He is also the Director of Post-Acute Services at the Uville Center for Advanced Therapy, a 33-bed post-acute facility. Overseeing a total of 241 skilled beds and over 1,000 admissions per year, Mr. Farrick is responsible for the day-to-day operations of both the skilled nursing facilities of Uville Life and Wellness Community Campus and more. So again, welcome to all of our speakers. At this time, I'm happy to turn the presentation over to Ellen C. Piola.
Thank you, Dawn, for the lovely introduction. We're so fortunate to be working as alliance partners with the New England QIN-QIO, and thank you so much for hosting this webinar and bringing us all together. So I'm Ellen DePello, and I'm the president of Honoring Choices, and as Dawn said, we're a consumer-focused group, and we inform and empower adults 18 and older to make a healthcare plan and then to connect to care right in their community. So we try to do this simply in two ways. We put free downloadable healthcare planning tools right on our website, including an original healthcare proxy and a personal directive. And then we give those tools and our programs right to our community partners because we know we can't do this alone. And our partners are anybody who can engage adults in healthcare planning conversations. So I want to tell you just a little bit about our model. Okay. Oh, sorry, we went a little quick there. One of the things I don't have is technical skills, so we're going to bear with me. But our method is pretty simple. When we talk to seniors and everybody, we really just say that everyone is on a healthcare journey, and that every journey needs a plan. So no matter where you are, whether you're young and promoting wellness, or even 80 years old and promoting that everyday wellness, managing your chronic illness, or living with serious illness, we believe everybody needs a plan, and that plan is just a roadmap to the best possible care at every phase of health. And that MOLST plan, medical orders for life-sustaining treatment, becomes part of that serious illness journey and one of the healthcare planning discussions. We actually hope it's not the first discussion people have. And so what Honoring Choices is doing is offering a structured approach to this so that everyone is using the same tools, the same language for effective care provider-consumer discussions. And when we simply present this to our care providers and our consumers across the state, we're saying, think about it like this. Step one here in this three-step plan is just to stop for a second and say, where am I on this journey? Where's my loved one? And what's right for me or for them? And to consider information so that you really have enough and adequate and good information to make those care choices, even before you pick up a healthcare planning document. And that's step two. There are 5 Massachusetts documents in the state, and when you're ready, you can start to write down those choices for care. And that third step, we're really working very closely with our care providers, is how then do we connect people to the care that they need right in their community. And that this isn't just about end-of-life care, but it's really how you feeling today. How do we get you the best quality care to honor those choices? So you'll see on the Honoring Choices website those free downloadable planning tools and discussion guides, and it really has been a team approach. Our care providers, who are anyone, our nurses, doctors, social workers, clergy, are all working together now. They all have the same tools. And at any point in time, anyone can start one of these planning discussions. So those 5 documents in the state, most people are familiar with. It certainly is the healthcare proxy. The Honoring Choices has translated it into 9 languages because our partners have told us throughout the state that in many cultures, within many groups, a healthcare proxy isn't something they're familiar with. So having it in your own language has really opened a lot of wonderful doors for families across the state. And so that's where we pick that agent. And in Massachusetts, we have a living will, or what we call a personal directive, to tell your agent what you want for care. So you can see these 2 documents really work hand in hand, and anyone on your team, any staff member, any volunteer, can start to talk about this discussion right away. The personal directive has been a wonderful document. It's actually been very useful for adults who do not have agents. And we have found out in talking with our partners that people are almost a little ashamed that they don't have someone to appoint as an agent, and it really prevents them from planning and talking to their care providers. So this is a great place to start. What we say to folks, if you don't have an agent, that's no problem. Start with the personal directive. It's a great, easy tool that says, what's important to you, what would you like for care, who would you like us to talk to if we can't talk to you. The other way that we're using this personal directive, too, is there's a pre-MOLST discussion. As we all know, MOLST is voluntary, and sometimes people are just not ready for that discussion. This document's been really helping people start to think about that type of care. And the third document in the state is the durable power of attorney. That is a legal document where we appoint a person to be our financial decision maker. And then the last two are the medical orders, the MOLST and the CCD&R. Those are your 5 documents in the state. Everybody can use them. They're your own personal documents. They're living, breathing documents. You can change them as long as you're competent right through your lifetime. We also have on our website for you discussion guides. We realized in talking to consumers, it's really hard sometimes to start this conversation. So we developed a 5 things to talk about guide that is the same for you as care providers to start with. And then we have the same guide for consumers, same questions, same format. You'll see on the left side, the blue column, those are what we consider the 5 basic rights for adults in Massachusetts. And we base some of those questions right on those rights. What our partners are telling us is that even though this can be pretty in-depth, sometimes just starting with question 1, tell me more about your illness, really opens this door pretty wide. So let's talk about MOLST. Most of you have seen this form, but if some of you haven't, this is the state form here. And it really is only as good as a discussion. It's not a checklist, even though in some ways it looks like one. It really is a discussion. We know the basics are for seriously ill and frail adults. This is a completely voluntary form. And that's something we want to keep in mind as we start to talk with people about this. How it works pretty simply, or how it's supposed to work, is that people with a serious illness or in a frail condition have a conversation with their care providers about their current condition and where they are on that journey. They learn about their what would be the benefits and risks if tomorrow, for instance, their heart and breathing stop. What would they want? Would they want their care provider to attempt CPR, ventilation, or to transfer them to a hospital? That A, B, and C on that form. And once a person has some sense of what decision they want to make, they with their physician or nurse practitioner or physician's assistant will check off that form and sign it in boxes D and E. It's important to know that there is actually no state MOLST regulations. And let me clarify what that means. We have MOLST guidelines in the state. We've checked with the Department of Public Health who oversees this form, and they're really clear that there are no real regulations. But sometimes what happens is we get confused. There are other regulations with assisted living, with nursing facilities, with hospice, that can conflict with some of these forms. So we want to continually be aware of this and see if we can open up this dialogue to make this easier for everybody to understand. Pink or white's the big question, but we can do either one. Our EMS folks and our ED professionals will tell us it's great to see that pink form, but it's perfectly fine to have this in the white form. And there's more information on the MOLST website. I'm going to advance this slide here. Got a little stuck. There it is. Okay, so last year, from April to December, we may have met some of you. We had 9 MOLST Meeting the Challenge workshops right throughout the state of Massachusetts, because we wanted to hear from our interdisciplinary care providers. What are the implementation challenges for you? What are those best practices? And some of them are big, and we need to work with them all together. But we wanted to bring you today some of the things we learned that we could immediately work on with the MOLST form. Especially from our 5 regional EMS directors, they were telling us that as they're seeing these forms, they are seeing them not finished and not legible, which makes them immediately not valid. So to make this form valid, we have to make sure sections D and E are completely filled out, all of those 8 lines, and it has to be legible. And it is really a heartbreak when families go through this and they learn at the worst possible time that this form is not valid because it's not legible or filled out. So everyone can just take a look at the forms as you're reviewing them with families. Just make sure they're filled out. And the decision-making power is something that comes up a lot. Now, as I said, these documents belong to the individual, but we can ask folks for their healthcare proxy and say, could we have a copy of that to put in our record so that we know what the decision-making power of the agent is? Do they have any and all powers, or are there some limits? They'll see it right there on the proxy. And to remember that the agent has, if they have any and all powers, they have the right to change this form and revoke this form. And with guardians, it's a little different. We want to ask for a copy of the court order because each guardianship court order can be quite different in terms of what was the permission, what happened, what did the judge say in terms of what the powers for the guardian was around life-sustaining treatment. So having those forms with the MOLST form can be really helpful to all of your staff. And the good news is we are joining the National Pulse Paradigm. So wonderful organization. It's 50 states across nationally here who are working on MOLST. It will stay on MOLST form. As far as I know, this is up to the Department of Public Health, and I know they appreciate input from us on how we should start to change and come together. But right now, your staff can go look at that website, thepulse.org, lovely webinars, a lot of great information. And lastly, we want to tell you that as we work through the state, we work with, on the MOLST workshops. We also work with those 5 regional directors. They have wonderful conversations about how do we do this better. How do we align our protocols and make sure those transitions are pretty smooth? So we just released the 5 things to do ahead of an emergency based on those conversations. Certainly the first one is making that form valid, making it visible, or actually what EMS says, meet them at the door. Either if you're in a facility, meet them at the adult room, or meet them at the front door. Remember, they need that form in order to know how to treat. They ask that we make 2 copies. EMS needs to have a copy for themselves, for their own records. And they can be really helpful here. If we get them a second form, they can transfer that to the hospital or to the next set of people who are going to help that individual. And set up a MOLST planning meeting, either at home with your family, suggest it for families, or suggest it at where people reside. We are finding that families are really having a hard time because they don't know what happens when there's an emergency. So talking about that ahead can be very helpful to make sure we're revising and updating those MOLST forms. And go ask your regional directors. If you have any questions about EMS, there's a wonderful group of folks in the state who are so willing to help. And so now I want to pass this to the next presenter.
It could be Dr. Dietzen.
Hi, so this is Dr. Dietzen. Hopefully everyone can hear me, and you guys are going to advance the slides for me. Is that correct?
Yes, that is correct.
Okay. So thank you, everyone, for being on the call. I want to talk a little bit more about MOLST and implementation of MOLST. Next slide. I think that as you've already heard a bit from Ellen, there's still a lot of general education that needs to be done about even the simplest steps in this process, like healthcare proxy and initial goals conversation. There's a lot of work being done around the serious illness conversation. And we really need to think about how to tailor this to different populations of patients and different patient and family needs. But for now, I just want to focus on the MOLST form itself, knowing that the rest of those things will remain a very important issue. Next slide. So I think when you think about educating providers and teams who are working with patients with serious illness about MOLST, you need to think about it in sort of 2 separate buckets. One is clinicians who are going to be discussing this form, and as Ellen already told you, the form has some complexities. It's not very user-friendly to patients and families. Clinicians really need to learn who are appropriate patients to select, how do they talk about the form, how do they talk about the choices on the form, how do they explain to patients and families the logistics of the form, what happens to the form after you fill it out, who has it, where does it need to be kept, those kinds of things. So that's one big set of people that need to be educated and have a process. The other set is really people who may not be the direct care providers who are discussing the form or completing the form with a patient, but need to understand how the form should fit into your healthcare system. So how is the system going to identify patients where this might be appropriate? Is there some way of providing general information to the patients before a visit or while they're in the waiting room or from the medical assistant who might be seeing them to give them background? Who's going to be tracking this information, and how do people other than the direct providers contribute to the system as a whole doing a better job of getting these documents completed. So I think it's often helpful to think about, again, those two separate categories of education and training that you might need to provide. Go ahead. There are lots of different methods that you can use to provide this training in both of those categories. Often it's helpful to go on-site to people's practices to provide this kind of education. You can certainly create online webinars and materials to do this. And again, the Honoring Choices site and the POLST and the MOLST websites have lots of excellent online educational materials that you can use. You can provide written materials and written protocols to support some of this discussion. I think if you go back to thinking about those two categories and groups, the systems-based knowledge and kind of the basic level of knowledge, I think, can be really well provided by online learning or written protocols. For clinicians who really need to learn how to discuss this form with a patient and how to help them to understand in layman's terms what some of these medical interventions would mean for them, I think in-person training is still the best method of doing that. And so I think you need to keep in mind that that kind of in-depth communication training is often best done in person. Next slide. So at Daystate, over the 6 years now that I've been here, we've had several different events to try to help the community understand MOLST better. One was a workshop in 2012, and another similar event was held just this last year in conjunction with Honoring Choices. They were continuing medical education events to which anyone in the community was invited. There was a mix of providers, nurses, social workers, physicians, sometimes administrative people from nursing homes or other facilities, sometimes emergency medicine personnel. And at both of those workshops, there was the intention of, again, talking about both pieces, the how do you implement MOLST where you are, and then secondly, the how do you really get the clinicians who are tasked with doing this the best possible skills in talking about it. I also have done multiple discussions of these issues in practice settings by going to groups of nurses on nursing units or going to ambulatory practices and talking about it, or talking with the care managers of our accountable care organization and providing them with basic information and training. I've also met with all of the hospitalists at Daystate, and I continue to meet with the new hospitalists to give them at least some insight into what the MOLST purpose is and how they should introduce that to patients. We've also created a local online continuing medical education activity that providers are able to do through the Daystate website. I think the key thing to recognize here is that the staff who are doing this and the staff who are implementing it to some degree are a constantly changing cast of characters, and so you do need to have some regular ability to provide education. Just training everybody once will only work for a few months, and then you'll have entirely new staff involved in the process who will need updates and further training. Next slide. So just to talk a little bit more, so we had an initial workshop in, it should say 2017, on the slide, to talk with the Honoring Choices team about the importance of this entire process of advanced care planning. And then we held a second workshop where we said we were going to really focus on the clinician training piece. As I said, I think this is best done in an in-person setting, and so we invited people who were interested in doing that from the original meeting to come back and have a 3-hour session where we really focused on the communication skills. We did this by writing some patient cases, really talking about what the advanced care planning issues might be applied to those specific patients, and talked about how to elicit the goals of those patients so that in addition to describing the medical interventions, you're matching them to outcomes that are important for patients and families. We gave sample communication tools such as the serious illness checklist and some other guidance around the MOLST form itself. We encouraged people in small groups to role play, asking some of these questions and answering family concerns in real time so that they had an opportunity to practice that language and understand and recognize some of the difficulties in addressing some of these questions in specific situations. I think it was a very well-received discussion among the participants. Everyone was very engaged in the process of the initial presentations and in the small group learning, and I do think that that's an effective way to reinforce communication skills. I think as often with these kinds of presentations, you will get some staff who are on the front lines describing a document like this and signing it with a patient and family, but often those providers are not the ones who are taking the time to come to a communication workshop, and so you need to continue to try, and we can certainly talk more about other ways to try to reinforce that that kind of training is incredibly important, and the more physicians and nurse practitioners and people who are really the ones tasked with having this conversation, the more experience and practice they have, the more comprehensive and more well-informed those conversations will be. Next slide. So we basically talked about this, but if you were going to try to recreate something similar to what we did, it was a 2.5 hour session. We accepted that people already had a basic overview of the MOLST and what it was, but we took 2 sample cases of a place where there might be a discussion about a MOLST form and encouraged initially a panel discussion among different clinicians who might be part of that process about how to have the conversation, and then a small group role play where different members of the audience took turns in small groups being the provider and describing and answering some of these questions, and then we debriefed as a large group. The total group was about 50 people to talk about what worked, what didn't work, what communication skills did people take away from that session. Next slide. So I think that there will absolutely need to be more and ongoing training. As I said before, I think there are lots of tools out there to use, and my hope is that we can continue to do this across varied healthcare providers, because I think it makes much more sense to do this in larger groups given the large number of clinicians and providers that we're hoping to educate. So I'll go ahead and turn it over to Mike Farrick.
Great. Thank you. So Ellen and Dr. Deason obviously did a great job and explained a lot about the process here. I'm going to take a small little bit of a turn and talk about how we here at QIN-QIO partnered with some of our key hospital partners and ACO collaborators to kind of shore up the MOLST process. So just to give everybody a quick overview of Duville. Life and wellness community. We are a campus that has assisted living, senior housing, but maybe the biggest thing that we do here is we have 241 skilled nursing beds, and we take care of an array of patients, everything from long-term care, which is probably the most of what we do, but also short-term rehab, people that are going to be here for just a week to a couple of weeks, and people that are here at end of life and getting end-of-life care, whether it be on hospice, palliative care, care and comfort only. One thing that many of our patients and residents do have in common is that they are elderly and frail. That is definitely the population we take care of. So, on to my next slide. Yeah, so some steps to think about. Again, this is kind of how we partnered, and I'll explain and expand upon more of each of these, but that meeting between the skilled nursing facility and your partners at the hospital or ACO to plan a collaboration and get on the same page about the MOLST form. getting the MOLST form, the sooner the better, and that doesn't mean when people are necessarily, not doing when people aren't ready, but not waiting until we're in an emergent mode to get it. Facilitating electronic medical record access, the skilled nursing facility policy, they should have a policy in place around this, and including MOLST as an incentive in a shared savings program, which is something that we did. So let's talk a little bit about the education. We had a meeting with our partners at the hospital and our ECO collaborators, and covered some of the main topics. What is the MOLST form? And like Ellen and Dr. Deason said, people may know what the form is and be able to talk about the acronyms, but how many people have actually seen it and utilized it on a regular basis? A lot of folks, even though they're aware of it, really need a refresher, and the collaborators need to get on the same page about what their understandings are about it, and maybe do education together about it. And also why the form is important. One of the things that we did is did some storyboards about some situations where things really didn't go very well for a particular patient because the MOLST form was in place, and then we can also go over some examples of why it's really helpful and why it's very important to have it in place. Another thing that is important to talk about is the barriers to obtaining the MOLST. And once this discussion starts, I think it's how much time do you have left in the meeting, because people will be able to bring up a lot of things that come up that make it difficult to obtain. But still, it's important to get those things on the table and start to talk about them. And also, who are the contacts for the coordination of this from both the skilled nursing facility and on the hospital ACOs? And usually in skilled nursing facilities, it's a social worker. But in the hospital, it could be, or the ECO could be someone completely different. They may have someone specifically monitoring compliance for this, or something completely different. But it's important to get those two people interfacing. So I mentioned the sooner the better, and I want to be clear that's not, when people aren't ready for the conversation. I think the key part about it is trying to avoid it happening, in an emergent situation. When people come to skilled nursing facilities, especially for short-term rehab, it seems, our industry is just so crisis-driven. Folks, are not prepared, no matter how much education you do to prepare for these things. It's always not a good time in life for an admission to a skilled nursing facility. Families have things going on at home. The patients themselves may have other things going on that they have to take care of. So it's a very, very trying time for folks, and they have their minds on a lot of different things. So if a resident or a patient is appropriate for the conversation, don't wait until we're at crisis mode to have it now. One of the things that we often talked about is the visits at the doctor's office, just a routine PCP office visit, is a great time to do it. They're going to be having the conversation, the family is going to be having the conversation with their primary care physician or NP or PA that they're more familiar with, hopefully. Maybe the conversation can be started during one visit and continue during the next visit. The MD or NP will be talking to them directly, and it just leaves more time for a detailed conversation about the MOLST form and end-of-life decisions. So again, the crux there is as soon as people are ready and appropriate for the conversation, don't wait. Don't wait until until the world and the sky is falling to have it. Medical record access. I think that a lot of skilled nursing facilities are already where they need to be with this, but it is important to we found it was important to give the clinicians from the hospital and the ACOs access to their medical record while they're here in our building. The reason being, when it comes to looking for the MOLST form, a lot of times because things get lost in translation, it's not in the paperwork that came here, and the family can't really, remember whether they did it or not. They're bombarded with paperwork all the time. So, having a clinician on site that's able to access the patient's medical record from the hospital or the primary care physician's office is a great and powerful tool to find the form sometime and not have to go, through the whole conversation, or bring that form to the conversation so we can kind of have a reminder of what's already been spoken about. Typically, when it's a web-based electronic medical record, it's pretty easy for a skilled nursing facility to give that access to the clinicians right here in the building. If it's software-based, you may need to engage your IT team a little bit. There's some more steps to that, and I'm not going to get into all of those, but just know it's doable either way and can be a very powerful tool to have. Skilled nursing facilities should have a policy for obtaining the MOLST. Who is the person responsible for doing it? Is it going to happen during admission? Is the education going to happen during admission, or is it going to happen in the first 72 hours? So I think just kind of outlining, what the SNF's plan is for educating and obtaining on the MOLST is very important for people to understand, not only within the SNF to have that process in place, but also for a hospital or an ACO collaborator to be in the know as well. Usually, if the SNF is going to be the one obtaining it, or they do obtain it, they shouldn't just obtain it and keep it in their records. They want to just disperse that out to the relevant parties, including their PCP, including a copy home to the family with some documented education, but adding that to the medical record so we can find it in the future easily if we need to. So incentives, it's not uncommon for SNFs and ACOs in their shared savings and their collaboration to include incentives for maintaining MOLST compliance. That is certainly something that many folks out there are doing. So, there can be rewards for hitting goals, or, increases in the shared savings if you're hitting goals, but it's very important that the, benchmarks be established and there's a reliable tracking system in place. The skilled facility usually is the one for obtaining it, left right on the right on admission, and making sure it gets to the right folks, and that's what we talked about last time, getting it to the PCP's office, making sure the patient is returning home with a copy, or getting that copy into the hands of a key family member, documenting and providing some good education to the resident and the family. So that's my last slide. I'm going to pass the ball on to Kate here.
Thank you, everyone. At this time, we'll take some questions. If you'd like to answer or ask a question over the phone, please press #6 to unmute yourself, or you can pose your question in the chat box. We already do have one question from earlier in the presentation that was asked over the chat box, and that was from Christine Pinatiello. Sorry if I mispronounced your name. She says, we have difficulty getting the time in Part E on the MOLST form. Is it absolutely required for the form to be valid? I can try to address that question, although I don't have a definitive answer for you. We've been talking to the Department of Public Health about that because they own this form, and to EMS because it is their protocols that really are pretty narrow. And what they're saying to us is that, if they've got a form and those 2 boxes are pretty much filled out, even if it's missing a time, it's not that they're going to be a stickler about it. And again, I'm trying to paraphrase what the 5 directors have said to us, is that they will, if they have questions about the form, they check in with the people they need to check into to see what the next steps are going to be. So at this time, I think, again, the bigger concern was, is it legible? Is that signer's name, the clinician's name, legible? Is that phone number there? And so that they can always check with those folks on things like time. That would be my best guess from what we've heard from EMS. Thank you. Can I ask now if we have any questions over the phone? Okay, we have one more question over the chat line. This one's from Debbie Logan. For a patient who lives over the border in New Hampshire, but their closest or preferred hospital and their medical doctors are in Massachusetts, do they fill out a MOLST, both? This is Ellen again, and I can tell you what we know about that. So right now, the way we're working with the MOLST form is that we don't have any reciprocity in other states. So if you have a Massachusetts MOLST form, it can only be honored in Massachusetts. Now, that's not to say that some doctors may not choose, over the border in New Hampshire or Rhode Island or Connecticut to say, maybe we can honor this. But they typically they can't honor it. But the good news is as we move to the POLST paradigm, the national POLST paradigm, one of the great reasons to do that is there will be reciprocity. So the MOLST form that we have right now, I believe we're still going to call it MOLST. Again, this is all forming, and I would suggest if you have ideas about this, to send them to Honoring Choices, or actually just to talk to the Department of Public Health about what would be best for your patients, especially if you're living on the border. But the idea is as we move to a 50-state paradigm, we will have reciprocity, and it will be able to be honored in the states on the border. I have another one, again, about the form, so this will probably be for you again, from Heather Fair. Does the second page at the back of the form need to be completed for the MOLST to be valid? We have some providers who do not fill out the back side, but then state it is valid. I'm happy to answer it, but Dr. Deaton, would you like to chime in on that?
I'm happy to. I think our answer would be the same, which is that you can choose to fill out, all of the form or part of the form. It might be important if the patient intentionally opted to only fill out the front of the form or only fill out parts A and B, to just make a little note that that was an intentional choice, but it is valid if it's signed no matter what parts of it you completed. Ellen, does that sound right?
Too, they actually operate independently, those pages. Great. Thank you. I just wanted to check and see if anyone had any questions they'd like to ask over the phone. Again, press #6 to unmute yourself. Okay. So we have another question from a follow-up from Julie Creighton to all participants. What if the date of the signature is not present?
In the other pieces, an independent psychiatrist, like with Dr. Bennett speaking on just consider. Somebody's not unmuted. If you could mute your line if you're not speaking. Thank you.
So this is Dr. Deaton. So the question is just about the lack of the date. Is that right?
Yes.
So I think that the time, which someone asked about already, is a little less important. I think people do feel that it's important that the form be dated. And so people will question a form that doesn't have a date on it in some form. Again, it doesn't mean that it's not a reflection of the person's wishes and could still be talked about as a reflection of their wishes, but it might, in some circumstances, have more difficulty being accepted as an actionable document with no date.
Thank you. The next question here is, does the original MOLST need to go with the patient? As we were discussing making copies, do we keep the copy and always send the original form back? I'm going to defer to Dr. Deaton there, since this is the actual work that she does.
So the pink form should stay with the patient, and copies of the form can certainly be placed in paper medical records or scanned into hospital computer systems or other electronic databases. But the pink form should stay with the patient, and that's part of the education that you need to provide to patients and families, is about where that document should be and how it should be located in an emergency.
All right, great. And we have a question from Rose. It's, what was the national organization that Ellen mentioned? It was not, it didn't show up, so we just are interested in the name of the organization.
Sure, that's easy. So that, if you Google POLST.org, I believe, you will www.POLST.org, I believe, you will get the National POLST Paradigm. And it is a wonderful organization that, again, is trying to make this work for all 50 states. And they have lovely downloadable and free webinars and fact sheets for everybody to enjoy. Another question we have from the chat box from Anita Christie to all participants. The discussion today is focused on providers in the healthcare setting. How do you approach this with families beyond the healthcare setting?
Maybe Mike would be able to answer that?
So, I mean, primarily the conversations that we're having with folks is in the healthcare setting. The one thing I can say that we've had some conversations with what's happening outside of the facility. We'll work with our VNAs and kind of the community-based nursing agencies that we use, and they can take part in any education we're having about the MOLST form, and they would be the ones who would try to educate and coordinate having the patient having that conversation with their physician or the physician's office, whoever they choose to do it if needed. So I don't know if that answers the question, but yeah, I'm not sure if someone's not kind of in the continuum of healthcare, what exactly would happen.
Yeah, so I guess this is Dr. Deason. So I think that you can do general community education, and I do think that there are great organizations, Honoring Choices included, that are out there doing that for groups in the lay public. They might be a hospital's community organization or an invited talk at a local library or those kinds of things. Those kinds of discussions, I think, generally are better focused on the entire process of advanced care planning and less about the MOLST document. When you get to the point of the document, it pretty much needs to include that healthcare provider as a part of the discussion, and so the rest of that discussion really does need to take place in a healthcare setting of some sort.
Mike, and I would agree with both Mike and Diane and say, what we're seeing, though, is such a curiosity about this form and how do we handle end-of-life care conversations, that what we hope we're doing with our partners are actually doing in Honoring Choices. Our partners are not just healthcare providers, but there are a lot of our community workers as well, our geriatric care managers and all of the VNAs, for instance, and the Council on Aging and the ASAPs are doing a wonderful job in using, for instance, the Honoring Choices tools to show that there's really a trajectory of discussions here, that we want to start these discussions early so that we can have an easy discussion about a healthcare agent, for instance, and a personal directive and work ourselves up to most. But what we hear is that everybody is actually can talk about the basic information about end-of-life care planning and when a MOLST form is appropriate and what some of those decisions might look like, and to become an educated consumer so that you can then go to your doctor or your clinician and say, is it time for us to talk about this? What are some of the discussions we might have? And that's been working really well throughout Massachusetts.
All right, thank you. I just want to make sure we're not skipping over anybody who'd like to ask questions by voice. If you would like to ask a question, make sure you press pound 6 to unmute yourself. Okay, we have another question from David Lennon to all participants. If medical doctors or nurse practitioners are the ones who are supposed to sign the MOLST, why are social workers having the conversations and filling out those forms?
Yeah, so I think that refers to something that I was speaking to, so I'm sorry if that's the way it came out. Just in the social workers are the ones who usually kind of coordinating the process. They're in charge of those first 72 hours of admission. It'd certainly be the NP and the MD that are having the conversation with them, but in terms of kind of tracking and coordinating, that's where the social worker is the key person in the nursing home. And other nursing homes may choose different people. They may have a different process. That's just what we do here at Duville.
This is Dr. Deason. I think what I would add to that is I think it goes back to kind of that systems education. As I said before, the actual filling out the form with an individual patient should happen with a provider, a nurse practitioner, a PA, or a physician who clearly has an understanding of the patient's medical condition and their goals and completes that conversation. But people like social workers and medical assistants and other people who are in a facility or at a primary care office can do a huge amount of the work in terms of educating people about why this is important, what kinds of questions may come up in this conversation, making sure that they are as prepared as possible and that they have the appropriate time and setting to have the conversation with the provider that will result in the form getting signed. So to me, that's the real importance of making sure that all of those other providers do understand is that they can really facilitate the systems part of getting this accomplished.
Great, thank you. Question from Judy Sullivan. When a patient is being sent to the hospital from a nursing home, should the MOLST be sent with them or a copy? Oftentimes when the patient returns to the nursing home, the hospital does not send the pink form back with the patient.
Yeah. So our understanding is that the copies are valid. So usually we would send a copy and keep the original if the original was signed here. If nursing homes feel that they need to keep or they need to send the original, then what I would say is that's something that you have to talk to the hospital about, whether it be the case management department or the emergency room, and let them know that you're really struggling to get original copies back of things you're sending there that you need upon return. It'd be something you have to kind of coordinate with them individually. But maybe Ellen or Dr. Deason could talk about the validity of a copy of the MOLST.
Yeah, the guidelines are really specific about that, which is that the copies are as valid as the original. We just want to make sure that from my point of view, that the consumer, the patient, really owns this form, that this is their form. So no matter where it's being done, that they should really hold that original, so that they also then, if they want to make changes as their health progresses and as their decisions change, they're really owning their own form. That would be our opinion. I know technically that can be a little difficult, but I certainly share the fact that we don't want to be losing these forms, and it is tough when we're transferring paper copies around. So I think it's just a discussion we can all have to how do we best do this so that we can keep these forms timely and updated and easily accessible for everyone.
And I will say that the state of Massachusetts is starting on a process to do what several other states have done, which is to have an electronic registry so that we don't need to be as focused on where the physical piece of paper is at all times. But we're not there yet.
Thank you. Question from Sandra Willette. I work as a conversation nurse with our VNA. I oftentimes have these chats with patients in the hospital about this, and they wish they do MOLST. How have others dealt with this, with getting the forms done upon discharge so the form follows the patient out of the hospital into the home? Dr. Jason, would you mind taking this one?
Yeah, no, I'm fine. So I think that the process that we do here at Baystate to try to assure that that's going to happen is we've educated the care managers about the importance of the form, and we've educated, as I mentioned, the hospitalists and the other care providers about the importance of documenting that anytime there's a substantive conversation in the hospital about wishes that could be written on the MOLST. So it's really a matter of continually reinforcing that idea that we should always be trying to create that document when the patient's in the hospital and has had any kind of conversation regarding their care wishes. I think what really helps is that, again, the care managers, our case managers who are responsible for the discharge process have been very much on top of it and will, call people and remind them and say, this person's leaving today. In addition to writing their scripts, I need you to make sure that you do the MOLST form with them and their family member, and tries to facilitate that. Certainly if you were a provider, visiting with someone in the hospital and you recognized that they might want to do that, I think it would be very reasonable to contact the provider, the clinical provider who was taking care of them in the hospital and say, can we all sit down together here for a few minutes and try to put in writing what this patient is expressing to me?
Thank you so much. We're running a little bit short on time, so I'm going to put one final question out, and if you haven't had your question answered, don't worry, we will get back to you separately. We just wanted to make sure that we have enough time to do our wrap-up here. So the last question is from Allison Witt. If you want to make a change to a MOLST question, do you have to do the whole form over?
is Dr. Dietz, and Ellen can certainly answer this question as well. In general, if the form is as clear as possible, that's better. And so if there's any question about something that might have been scribbled out or changed, that could lead to some concern in the moment of, when decisions are being made. So better, if you need to change something, to do the form again and make sure that it's as clear as possible.
Thank you. And just one more question, just so that we're clear. Is a medical and social worker qualified to complete the MOLST in the essence of an NP or PA? That was one more question from Amy.
According to the guidelines from the state right now, it's right written there on the MOLST form. We have physicians, nurse practitioners, physician assistants, and DOs are allowed to sign that form right now. And other than that, I don't believe there's been any other extension of that to date. Dr. Beeson, would you agree?
No, that's correct. So again, it's the difference between a social worker who might facilitate that conversation, but in order for it to be a valid document, at least a piece of the conversation that the provider would need to feel comfortable that the patient expressed their wishes has to take place with one of those providers who can sign.
Okay, since there's only one more question in chat, I think we'll switch it in. It's from Julie Creighton, and she says, when is the optional section used?
I generally, as a provider, only use the optional section if a patient has a very specific thing that has come up in the conversation that they would like to make sure that they express. Every once in a while, patients will want to make sure that we write in there that they do want antibiotics, or they don't want antibiotics, or they want some other measure that's not a specific thing on a specific item on the MOLST form. Or sometimes people just want to, use that to sort of reflect a general expression of what's important to them, and I certainly let them write that in as well if that's come up in the conversation and they say something like, I want my family to understand that I don't ever want to be in this position, or that this kind of quality of life is very important to me. I let people write that in the form so that it's there for them.
Thank you so much. And thank you all for a great discussion. I have a few final announcements before we end today's call. I just wanted to alert everyone that we are looking for volunteer advisors to join our Patient and Family Advisory Council, PPAC. You can share your healthcare story, give your opinion about patient handouts and other materials, use your experience to help improve healthcare in New England. We would also love to share with you our virtual learning system, the Learning Center, which hosts free courses available to all healthcare providers. Courses are laid out in bite-sized chunks, and some even have continuing education credits. The Learning Center can help practice managers in identifying gaps or opportunities in training. We invite you to visit the Learning Center at learningforquality.org. If you have any questions, please send an email to learning@healthcentricadvisors.org for assistance. As you can see from this slide, we are now on social media. Please connect with us on Facebook and or LinkedIn for the latest resources, webinars, and other offerings from the New England QIN-QIO. When you close out of this webinar, the evaluation will automatically pop up on your computer. If you could please fill that out, we would greatly appreciate it. If you don't have the time to fill out the evaluation right now, or if you're sharing this computer with somebody else, you'll receive an email tomorrow with a link to the evaluation, as well as a link to the event page on our website. The PowerPoint presentation was in your Day of Details email and is listed on the website. We will add that link in chat in case you missed it. Within the next few business days, a recording and transcript of the webinar will be posted to the event webpage. And we thank everyone for attending, and have a great day.